Yeah, so I think that we all do genomic testing at the beginning of therapy or even when they're diagnosed to help determine when they might need treatment. But really, currently, genomic testing doesn't really tell us what therapy to choose. I think if you were to poll a bunch of CLL doctors, they would tell you that patients with high-risk disease, as demonstrated by deletion 17p, TP53 mutation, or complex karyotype, are more likely to give BTK inhibitors, as there's been data that shows that consistent therapy with a BTK inhibitor shows that patients with high-risk disease, it doesn't really come out as much of a significant prognostic variable as it used to. Whereas when you look at the Venetoclax plus Obinutuzumab study, that patients with deletion 17p do appear to be relapsing. So it is coming out as a prognostic variable. So there's something to continuous therapy being needed for patients with high-risk disease, but I don't think that's the be-all and end-all, meaning that in general, when I'm talking to patients about whether or not to go on a BTK inhibitor or to go on Venetoclax plus Obinutuzumab, really I use their understanding of time-limited therapy versus lifelong, or I should say long-term therapy. And many patients really want the time-limited therapy. And although I do suggest to them that I think that they should go on continuous therapy with a BTK inhibitor at this time, if someone really wants time-limited therapy, just because they have high-risk disease, I don't necessarily not give it to them. It's not contraindicated per se. So I think that, once again, the story is still be written about whether or not we should be using genomic features that determine which therapy we should give patients. And in general, for high-risk patients, I am favoring a BTK inhibitor.